The case that we highlighted today is a very typical presentation for a patient with mantle cell lymphoma. Although it's an unusual disease, it does comprise up to 10% of all cases of non-Hodgkin lymphoma. And fortunately, it can be fairly easy to diagnose based on the fact that it almost always has a translocation 1114, as well as cyclin D1 overexpression by IHC. So from the pathologic standpoint, this is a very clear-cut case. It also is a disease that tends to impact men over women and also tends to present in patients in their 60s, similar to what we saw in this case. Now, not all cases of mantle cell lymphoma are the same. There are some patients who present who are entirely asymptomatic, where this is really found either on blood work or on a scan that's maybe obtained for some other reason. On the other hand, there are patients that present like our patient did, with weight loss and symptomatic lymphadenopathy and splenomegaly. There's a number of different ways that we can identify a patient's prognosis. Ultimately, a patient who is ill and who has rapidly progressive disease is one that you're going to worry about more than a patient who's asymptomatic. But there are also objective criteria, including the Mantle Cell Lymphoma International Prognostic Index, or MIPI, which was calculated in this case as well, which can help inform what a patient's overall survival will be. And these are factors that can be identified early on that include lab work as well as age and performance status. Making the diagnosis of mantle cell lymphoma can be relatively straightforward. There are a number of markers that we can look for, including translocation 1114, as well as overexpression of cyclin D1, and expression of CD5, which is not typically expressed on B cells. In addition, however, to making the diagnosis, there's a number of different pathologic criteria that we can use to help inform our understanding of that patient and their prognosis. One easy to calculate index is the MIPI, or Mantle Cell Lymphoma International Prognostic Index, which incorporates lab work as well as other clinical features. Pathologically, however, there are additional markers that we rely on. So for example, the Ki-67 proliferative index can be determined by the pathologist who's reviewing the tissue biopsy. This is an IHC stain. When a patient has a Ki-67 proliferative index of greater than 30%, it tends to confer an inferior prognosis. And in fact, in some instances, the Ki-67 has been combined with MIPI to form an even more robust prognostic index. And then additionally, there are some emerging genetic markers that we can look at that do identify patients that may be at an increased risk for early progression and potentially death from the disease. One of the most well-known genes is TP53. This can be screened at the time of diagnosis, and patients that have a mutation in TP53 are known to have an inferior prognosis and tend to not respond well to our standard therapies.